welcome you all to this virtual Women's Health Research Seminar that's convened by the Partnership for Women's Health Research Canada. And as a housekeeping issue, suggest that you turn off non-video participants. So you can do that in the upper corner of your screen. And without further ado, I would like to welcome Elder Valerie Nicholson to start us off in a good way this morning and this afternoon.
Thank you so much, Tamia. Well, Ellen, Kwe, hello. Otala Jiha, which is welcoming. Oh, sorry, wrong one. There we go. I invite you to put your feet on the floor and take a deep breath in and feel the energy of Mother Earth. Linda Louisi Valerie. I just said my name is Valerie. The name given to me 4 days after my birth was the one the eagles watch over. I've been gifted the name Noti Wenda, which means wolf eyes, from a Dene family, and I've been gifted the name Auntie from the Torres Strait Islanders. I am Mi'kmaq, Kaida, Roma, and UK Islander descent. I am a mother and a grandmother, and I am living with HIV. I acknowledge and honor all the ancestral traditional lands and waters across our great land from coast to coast to coast, and all lands around Mother Earth, where we work, play, live, and especially learn from. I honor those that walk these lands since the beginning of time. They are protectors of the lands and waters, holders of knowledges, and keepers of the medicines. May we protect Mother Earth and the waters. I honor elders past, present, and emerging. I acknowledge the unceded ancestral traditional lands and waters of the Coast Salish, for this is where I connect my mind, body, heart, and spirit. And today I am speaking from the Squamish and the Lillooet. I would like us to take a moment to remember those that have gone on before us and that their voices will be forever heard. I open with words of my grandfather with his Mi'kmaq teachings that new knowledge is old knowledge to new people. And as teachers, we are learners, and as learners, we are teachers. And in his teachings, I acknowledge the 7 directions. East, the direction of the sunrise and new beginnings. Each new sunrise brings us new light and new opportunities to grow in wisdoms. I ask the grandmothers and grandfathers of the East to always place light in our words and in our hearts and on our paths. The East gives us the gift of awareness, and I give thanks. South, the direction of summer warmth and abundance. I ask the grandmothers and grandfathers of the South to bring us the warm winds of compassion, whose fragrance speaks of distant springs and summer days, to melt the ice that may gather around our hearts, dissolve our fears, melt our hatreds, and kindle our love into flames of true and living realities. South gives us the gift of understanding, and I give thanks. West, the direction of the setting sun and the autumn season. I ask the grandmothers and grandfathers of the West to remind us that the end of our days is no more sad than the end of a single day, and the end is often better than the beginning. West is the direction of the elders, and I honor our elders as the keeper of wisdoms and the teachers of patience. West is also the direction of our ancestors, and we proudly acknowledge those who have gone on before us, and I ask for their guidance so that we can live our lives as we should. West has given us the gift of knowledge, and I give thanks. North, the direction of the winter that covers the earth with a sparkling crystal carpet, whose deep tranquility, every sound is beautiful. I ask the grandmothers and grandfathers of the North to temper us with strengths to withstand the biting blizzards, yet make us thankful for the beauty which follows and lies deep over the warm earth in its wake. North gives us the gift of wisdoms, and I give thanks. Up the direction to our great chief, the creator, our ancestors, grandmother moon who watches us over at night, Father Sky, holder of the clouds and rainbows, and grandfather sun who warms us. As we look upon the day's infinite blue sky or admire the countless stars at night, we're reminded that the Great Spirit is vast, beautiful, and majestic, beyond all our knowing or telling. And we're reminded that the Great Spirit is no further from us than tilting upwards of our head and raising of our eyes. We offer our thanks for all things of creation and being allowed to be a part of it. We offer thanks for the visions and dreams that help us remember who we are, why we're here, and ask that all people be given this wonderful gift. The direction of up gives us the gift of visions, and I give thanks. The direction of down, as we look downward upon this great land and Mother Earth and her lifeblood water, which is our source of life. I give thanks to our Mother Earth for all that we have, our food, water, air, shelter, and so many beautiful things to our brothers and sisters. We promise to always walk softly upon her face, for underneath our feet are the roots of the trees, the flowers, and the grasses. And there can be no greater aspiration than to strive for a deep respect and connection with all our relations, and always remain aware that we're all interconnected in this web of life. The direction of down gives us the gift of connections, and I give thanks. The seventh direction is the direction of within, and acknowledge and honor our own spirits. We often don't consider ourselves to be of value or to be important, but we are. We're an essential part of life. We are life in action, loving, moving, and growing. In our center is the home of our heart. May we always return to this place so that we may know the meaning of our journey. From here, the center of our being, we can reach out to all directions and to all our relations. We must always remember to be humble, for we are not the center of creation. Within has given us the gift of home, and I give thanks. I ask us to open our minds, bodies, hearts, and spirits to hear the words that we're going to hear today, and may we do it with respect, which is represented by our buffalo, love, the eagle, honesty, our Sasquatch, the turtle who carries our truth, the wolf who represents humility, the beaver with much wisdom, and courage, the bear, for it takes courage to make change. Nasamat is a Musqueam word, for we are all one. Aho, Wielan, all my relations.
Thank you so much, Elder Valerie, for bringing us to ourselves and to each other as we begin this session, and for sharing your wisdom with us. My name is Tamil Kendall, as I mentioned, and I'm the director of the Partnership for Women's Health Research Canada, or POWER. And POWER is an alliance between the Women's Health Research Institute in BC, the Women's and Children's Health Research Institute in Alberta, Women's College Hospital Research Institute in Toronto, IWK Health in the Maritimes, and the Women's Health Research Cluster that's based at UBC but is international in scope. And POWER is supported in working to realize our vision by our sister foundations, which are the BC Women's Health Foundation, the Alberta Women's Health Foundation, and the IWK Health Foundation, and of course the Women's College Hospital Foundation. So POWER's vision is better health for all women, trans, and non-binary people through research equity, excellence, and inclusion. And we use the term women to refer to all who identify as women and non-binary and trans as umbrella terms that refer to people with a wide range of gender identities that are different from those that they were assigned at birth. Part of achieving Power's vision and mission is to have this national conversation about how research can inform and accelerate transformations of policies and practices. And so all of you are part of co-creating and expanding this important conversation. So please, as we go along today, please share your thoughts, your questions, your musings in the chat, and we will pick those up in the discussion. Now, to begin in this third seminar in this series, which is about knowledge mobilization on partnering with policymakers, it's my great pleasure to introduce Dr. Angela Kaida, who is a distinguished professor at Simon Fraser University's Faculty of Health Sciences, and also the new scientific director of the CIHR's Institute of Gender and Health, and a very dear colleague. She's going to share her thoughts about partnering with policymakers in research for knowledge mobilization and do us the great honor of moderating today's panel. Angela, please, the floor is yours.
Oh. Well, thank you so much, Tamil, and it is so lovely to see many familiar names and photos on this call. Thank you, Tamil, and the organizers for bringing us together for such an important conversation today. And I would also like to acknowledge that I am privileged to live, learn, play, work on the unceded ancestral traditional territories of the Coast Salish people, including the Musqueam, Tsleil-Waututh, and Squamish First Nations. I do have to take a moment today also to acknowledge our friends, our colleagues, our community members from Williams Lake and Indigenous people across the country. As many of you know, we've recently heard of another potential burial site at Williams Lake, which is only 500 some kilometers north of Vancouver. So I want to honor everyone who lives with the trauma and the cruelty of our colonial past every day, but may be experiencing grief and trauma in acute forms today with each new discovery. And I do want to also thank Elder Val for opening us in such a beautiful and invigorating way. You bring such life to these spaces, these online spaces, Val, so I'm grateful for that. As Tamil mentioned, I am the new scientific director for the CIHR Institute of Gender and Health. I'm 3 weeks on the job, so I'm looking forward to meeting many of you over the next year and continuing these discussions. But I'll just really say that, of course, this conversation about partnering with policymakers is so essential to our work as women's health researchers. The gap, as we well know, between the incredible research that we do in this country in the space of women's health and the gap between its implementation, its uptake to making a real difference in the lives of women, cis and trans women, non-binary folks across the gender diversity spectrum. We need to close that gap. We need to do that work faster, better, more sustainably. And we're really lucky here today because we have 3 really incredible researchers that I think have fantastic experience and insight into how to do this. And unfortunately, I think I'm not telling you anything you don't know about the importance of moving research findings into implementation. But what we also know is unfortunately, there's no recipe, there's no map, like this is how you do it. But what there is, and what we have with us today, is guidance and best practice and experience. Folks who have traveled this knotted journey, this knotted pathway from research and into partnering with policymakers and then into implementation. And so I am really excited to hear from the 3 of them today. And just as we get started to do that, I really want to encourage everyone to use our chat function today. really have a lively conversation. The presenters have indicated that if there are technical questions that you're looking for some clarity on during their presentation, please use the chat to ask those types of questions. But we will be kind of gathering your comments and your questions for the discussion period at the end of our hour together. So really trying to reserve that final 20 minutes that we have together to bring forward these bigger questions and comments and things for us to think about as a community. I'll also invite you, if you have a question or a comment that you don't feel comfortable putting publicly into the chat, please feel free to DM me directly, and I'll be happy to share your comment and question on your behalf anonymously. So I think on that note, I'll encourage all of us to think also as we're listening to these presentations about how we think of women's health research, how we think of women, who are the women that stand to benefit from this, how can we bring intersectionality and an equity lens to our policy making, ensuring that we are really focused on those women who have been most marginalized by our systems, by the research that we conduct, and really doing some, I think, heavy work and big thinking about how we ensure that this is not research for implementation for, easy to reach women, but for all women. So I think that's just such an important part of our conversation in the women's health research arena right now. So without further delay, let me get us started here with our first presenter. So we are fortunate to have with us Dr. Wendy V. Norman. Many of you know Dr. Norman from her incredible national leadership, and we're fortunate, Wendy, to have you here today. She is a professor in the Department of Family Practice in the Faculty of Medicine at UBC, and is also the co-director of Canada's Contraception and Abortion Research Team. And today, Wendy will invite you to speak to us about your experience and your work on Canada's Sexual Health Survey from idea to implementation. Welcome, Wendy.
Lovely. Thank you very much, Angela, and thanks for the opportunity to be here. Let me just share my screen here. Are my slides showing now?
Yes, they look great.
Great. So I'm delighted for the opportunity to be able to present here today. I'd like to acknowledge that I am grateful and realize my privilege as an uninvited white settler and with my own Icelandic and British heritage to have the opportunity to live, work, and play on the ancestral and unceded territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh. And I bring my respects to honor the elders of these lands and those across Canada or Turtle Island, past, present, and emerging. I have no relevant disclosures to make and want to start out with the take-home points. And this is not only the take-home points for this presentation, but also one of the points when you're presenting to key knowledge users and working with government, start out with what you want them to remember when you go away and try to keep it to 3 points or fewer. So in this case, what I would like you to remember are to find the right policy makers to be able to understand the strategy and vision and policies that these people need to achieve and work for, and how that might align with the research that you're proposing and the collaborations that you might want to bring together. Collaborate widely across sectors. You bring a lot of confidence to your government knowledge user and policymaker if you can show that you are collaborating with all of the sectors and experts that would be interested in the kind of research question or in the eventual policy that would come through. So try to build collaborations widely to give them that confidence for you. And to remember that the academic policymaker duad is actually a two-way street. If you would like them to participate in your research, to use your evidence, then also be available for them to provide service when they might need a rapid review or response to media or something where the knowledge that you bring or that of your team could support them to be able to do their job well. There we go. So we'll just take a look at several areas today in this instance of how to collaborate with knowledge users in government. We'll look at a health problem, at how collaborative identification and prioritization of the question, engaging those people that you want to use the results, is important. Our research approach in this case, choosing a sexual health survey, the provincial policy outcome that we were able to achieve, how we began with federal policy engagement, the principles we used, and the federal policy outcome. So with no further ado, I had been a primary care practitioner for 20 or 25 years before I started into research. And it was just very clear to me from the coalface of primary care practice that unintended pregnancy is a massive problem with a huge intersection with structural determinants of health and intersecting determinants of health, and with intergenerational consequences. And many of you may have seen the 2022 UN FPA annual report declaring the unseen crisis of unintended pregnancy and the intergenerational consequences. Conversely, those who are able to time and space their pregnancy, the pregnancy capable people are better able to finish their own education, to contribute to society and the workforce, and their children, those who have been planned and timed and spaced, are better able to ensure that they have had food safety throughout their childhood, that they are have adequate shelter, and that they're able to achieve their own educational and eventual workforce goals. We see conversely a concentration of those with the poorest determinants of health when we look among those with unplanned pregnancies, which constitutes over 40% of pregnancies, most of which will result in an unintended birth. With about 1 in 3 pregnancy capable people across Canada having at least one abortion over the course of their lifetime. So we brought together the different sectors that might be interested in this problem to identify our research question. We convened the Chief Public Health Officer of BC, the leads for appropriate ministries and divisions within the government, the health services leadership, the leadership at BC Women's Hospital. And BC Women's Hospital in this case was key to helping introduce us to the key government people who would be interested, as well as to reaching out to the regional leaders that were concerned with women's health in all of the different areas of British Columbia. We brought together healthcare professionals from a range of disciplines and from each of our regions, and invited widely stakeholders among patients, among Indigenous organizations and advocacy groups, and not-for-profit organizations interested in these questions. And we sat down with a range of academics, about 11 different academic disciplines coming together in this way. We brought our trainees and focused on some capacity building. We set up advisory councils and a national network. And for this BC question, we convened everyone in a conference, and the conference that was 2009 started to build our relationships, and then in 2010 we brought this question together: what could we do together to be able to address unintended pregnancy with this group, our Chief Public Health Officer, the regional leads, the government disciplines, as well as the healthcare providers and patients. And we've been doing this every couple of years since, to ask and answer the key priority questions. We're currently planning for our 2024 meeting, engaging those who are there. And in each meeting, we bring the results from our previous meeting to say, here's the identified priorities you identified, here's the research we've been able to do on those. And then the government stands up and says, and here's the policies we've put in place. So it's a very iterative, very rewarding iterative process of engagement and of doing what we'll say we'll do, and communicating with these groups. So in this meeting, we recognize that in almost every situation where universal healthcare pays for the management of all pregnancy outcomes, except in Canada, all others are providing subsidy for contraception, so that there isn't a disparity across social determinants of health on access to contraception. So the group identified the key question: is, would universal contraception subsidy be cost effective? And I remember at the end of our working group sessions having Dr. Perry Kendall, who was our chief public health officer at that time, stand up at his table and bang on it and say, we need to see free contraception. This is how our research collaboration began. And we wanted to see, well, if we were trying to provide evidence to the government on whether this would be cost effective, what would we need? These are the indicators we'd need to find and their relationship to social determinants of health. And it turns out that these are not collected in Canada. So in order to do this, we needed to develop and field a representative sample sexual health survey in the province of British Columbia. We looked to global best practices. This has been done iteratively throughout the United States since 1973, and since 2006, continuously sampling. And in the UK, similarly, since 2000, they've been running a survey, which is now on its 4th iteration, just being fielded as we speak. We brought forward these validated questions. We pilot tested them in BC and implemented in 2015 throughout the province. Our CIHR funding was very limited. We had, I think, $400,000 in total to develop and field and knowledge translation for this project. And so we very much focused the survey in on the family planning questions of interest, although sexual health surveys typically cover a much greater range. So our response rate was fabulous. We had a 40-minute personal interview question household survey going at knocking on doors around the province, and 75% of people said, yes, I'd like to answer your survey. This was among reproductive age, pregnancy capable people only. And our response rate was actually higher, over 85 and over 90% in many of the rural areas. We were very representative across the social determinants of health we were able to collect. And we found that very few reproductive age pregnancy capable females at any age were currently trying to get pregnant, that most were not intending currently to be pregnant. And when we looked among those not intending to be pregnant, but having heterosexual intercourse, the proportion that were using effective contraceptive methods was fairly small. And here you can see the dark green and lighter green. This is the effectiveness of contraceptive methods, with the dark green being the most effective, red being no method used at all. And you can see that the most fertile age ranges were using the least effective ways to prevent pregnancy among those who did not currently want to be pregnant but could be. So this is where we learned that 40% of the pregnancies that had occurred in the last 5 years in BC were unintended, and that nearly 2/3 of unintended pregnancies resulted in a birth, resulting in about 1/3 overall of the births being unintended. Our key findings then were that we had a great representative sample, that those with the poorest social determinants of health were most impacted by unintended pregnancy, and particularly the likelihood that that would go on to a birth for a child that had not been planned. We brought together the data that we were able to collect then, that we originally had set out we needed to answer our original question. We used discrete event simulation modeling, coming to within 1% of estimating the actual number of pregnancies in BC. And then we were able to adjust the model for what if contraception were free. And we were able to show that although the government expenditure in the first year to provide free contraception for everybody front-ended would be over $20 million, that by late in the second year, this would cross the line so that government expenditures for all pregnancy care and for the free contraception would become cost savings by the year 3. And from the year 4 and for each subsequent year, that there should be a savings in the nature of $37 million a year over the health system costs for managing all pregnancy care. So our provincial policy outcome then was good news in the mandate letters of November 2020, and also most recently, as Mr. Eby became our premier in December 2022, the mandate to the Minister of Health to make prescription contraception free for all people in BC. And this is, we've been privileged to be working with the government towards the implementation of this, and we're imminently hoping for announcements. the federal policy engagement then, now that we've learned something about this survey, how could this align with federal strategic goals? We presented the results that we had on the BC survey at the Committee for all Chief Public Health Officers across Canada, and they all wanted this data for their province to be able to inform their own decisions on sexual health. And we started to make presentations to see where this would align with federal goals. We could see that the Public Health Agency's own annual review had said that they do not have adequate surveillance on a range of public health factors. We can see that STBBIs actually do not have representative sampling in Canada, that they're largely dependent upon sampling at sexual health survey sites. And yet there's a sexual health survey need to be able to understand better the determinants of health. We linked the WHO frameworks for sexual and reproductive health to what was being collected in Canada, and could find that across the range of frameworks other than maternal health, that Canada was not collecting sexual and reproductive health indicators. And we linked to the UN Human Rights Committee's decision on Canada, where Canada was told that they are inadequately addressing social determinants of health and sexual and reproductive health rights in a range of ways across the areas that the UN Human Rights Commission would expect for Canada. So we looked at WHO strategies to address this issue and how a sexual health survey could help. We could see from the Sustainable Development Goals we could bring to the Canadian government all of the kinds of indicators they require internationally that are not being collected. We looked to the Chief Public Health Officer's strategy for better health equity and the measures required there that are currently not being collected, and brought together evidence briefs for the federal government to be able to show the kinds of things that a sexual health survey could do to better their own aims to achieve health in the population. Was honored to represent the government in the WHO group, looking to see what are the ideal sexual health questions and to show what these indicators could do to be able to support Canadian government health. So we proposed a national survey based on our BC pilot that was expanded in both its sample and in its framework, bringing in then all of those sexual and reproductive health questions that would be important for the different indicators looked for internationally to meet federal policy targets, and to look at what the potential impact of having those indicators would be, and present these across a range of government knowledge users in the Ministry of Health, in Health Canada, the Public Health Agency. We made presentations to women and gender equality, to deputy ministers, to opposition parties. We worked and collaborated with community organizations, Action Canada for Sexual Reproductive Health, and a large national collaboration that they brought together. And at all of the intersection points we could find, we brought forward the evidence on how the health of Canadians could be improved. And in fact, we, in the end, had a positive federal policy outcome. In the federal budget of 2022, Statistics Canada was mandated to create and implement a national sexual health survey, and $7.6 million was allocated to this, which I think is like much better than the 400,000 we had in BC. And just to say that I think Canada is far ahead of our nations such as the US with the National Survey of Family Growth, the UK with the their NatSal survey, and many others. This National Sexual Health Survey will not be housed in a research team, as has been the case in so many other places. In Canada, this is a federal priority that the government will be managing. The data will be available in the Statistics Canada research data centers, linkable to all of their other data sets. I think it's a far more ideal outcome than having a researcher get the award for this. So take home points back right to the beginning where we started. Find the right policymakers. Each of those people in government wake up in the morning wanting to achieve the goals in their job. If you can assist them by bringing your evidence and knowledge and your collaborations to support them advancing their policy, then it's a win-win for both sides. Find that alignment and make sure that you listen to the perspectives and guidance of your knowledge users. Then collaborate widely across the sectors, bring in all of those that might be interested partners, engage them and listen with them as well. Build and maintain your trusted relationships. And remember that collaborating with policymakers is a two-way street. If they ask you for evidence, try to make the response on a government timeline, not a research timeline, 24 or 48 hours. Get your evidence together and give them a brief. Don't give it 4 months and wait for funding. So just to thank the very wide range of partners that we've been able to have the privilege to work with for our program of research, the partners particularly engaged with our sexual health survey, and to encourage you to write if there are any questions.
Whew. Thank you so much, Wendy. That is really a tour de force. I've heard this in the past, but every time I'm just really amazed by what you managed to accomplish. And I think there's a lot here for us to think about in terms of sustainability. So I hope folks have some questions that are emerging for them, like this question of like, all right, when you start, you move from BC to a Canada-wide approach and then integrating it into government policy, which is really fantastic. So in the interest of time, I'm going to encourage everybody who has technical questions, please put them into the chat. Dr. Norman will be happy to answer those in real time. Other questions, I'll move to the moderated discussion section. But let me now move to introduce our next speaker. It is an honor to welcome Dr. Jane Schultz to our panel today. Dr. Schultz is a professor and chair in the Department of Obstetrics and Gynecology at the Lois Hole Hospital for Women at the University of Alberta, and Alberta Women's Health Foundation Endowed Research Chair. So Dr. Schultz, we're really delighted to have you here and looking forward to your presentation on the obstetrical anal sphincter injury and the pathway to care. Over to you.
Thanks so much for the kind introduction, and I really am very humbled to be invited to be part of this group today, so thank you for having me. So I'm going to speak to you today a little bit differently. Ours is on a provincial level with provincial policymakers. And I'd just like to start by acknowledging that I'm in Edmonton and I work at the University of Alberta. And we are located on traditional territory of Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe nations, which are part of Treaties 6, 7, and 8. And homeland of the Métis. And we respect the sovereignty, lands, histories, languages, knowledge, systems, and cultures of First Nations, Métis, and Inuit nations. So today I'm doing a little bit more of a story, and this relates to obstetrical anal sphincter injury. There are a few graphic slides, so I apologize for that. I'll try and warn you ahead of time. I'm going to talk about a little bit of the background and then how we've gone on this journey and our vision for the future. I want to acknowledge my team. So I work as a team of 7 urogynecologists. So we're trained as obstetrician gynecologists and then do additional training in pelvic floor and urogynecology. And this is my group that I work with. Obviously, we cannot do this on our own. So why am I even talking about this? So as an obstetrician gynecologist and then someone who deals with the consequences of childbirth injury, for the obstetrical anal sphincter injury, it affects about 1 in 20 vaginal births. And it's certainly higher in women who have assisted deliveries. So if you have a forceps delivery or a vacuum delivery, compared to people that just have spontaneous vaginal deliveries. The rates have come down because of less instrumented delivery and more restricted episiotomy use. However, if you actually look at these women and do ultrasound, up to 50% of women may have these injuries to their muscles at the time of birth, and they may not be identified or detected. So I'm just briefly going to talk a little bit about anatomy and what's going on. So there may be a couple of graphic images. So when you have a baby, the normal anatomy is on the left side of the slide. So the bladder is sitting in the front here, vagina in the middle, and the rectum in the back. And as the baby is coming through the birth canal, you can get injury to the muscles and ligaments in the pelvis with tearing and stretching and damage to the nerves. And what often happens at the time of delivery is that there is disruption of these muscles in between. And there can be tearing right through to your anal canal. And then we do try and repair this at the time of delivery and put these muscles back together. So there is injury between the vagina and the bowel. These injuries are classified. So a first-degree injury means there's just some injury to the skin. A second-degree injury means there's injury to the muscles between the vagina and the anal opening. But if you get an injury into the rectal area, we classify them as third or fourth degree tears. So if you have injury to up to half of the sphincter that controls your bowel, it's a 3A. If it goes through part of the whole of the external sphincter, it's 3B. If it involves the internal sphincter, it's 3C. And if it goes right into the anal canal, it's called a fourth degree tear. And that's what I'm talking about today, is the injury to this anal sphincter mechanism. So why do we even care about this? So the challenge is that the long-term consequences of this to women can be quite significant. So you can have loss of control of your bowel, difficulty getting to the bathroom, loss of control of your bladder, pelvic organ prolapse, which means the organs are hanging out of the vagina, rectovaginal fistula, which is an abnormal connection between the bowel and the vagina, and the poop is coming out of your vagina. A lot of women have difficulties with pain, and that affects their bowel and bladder function and also their sexual function. And the big challenge with these disorders, pelvic floor disorders, is they have a huge social stigma, and only 25 to 30% of women often will come forward with concerns about these health issues. In terms of bowel incontinence, which obviously has a profound impact, as I said, only 20% will report symptoms. And risk factors include having a prolonged delivery, a vaginal birth after a C-section, use of an epidural, instrumental delivery, birth weight over 4 kilos, or if the shoulder gets stuck at the time of delivery. So when I started in practice in 1999 in Edmonton, you start seeing these patients coming through the practice, and people coming from outside of Edmonton and also from Northern Alberta. And concerns were that access to care differs based on geographic location. And then you're compounding this with the social stigma of the health concern. So I had a summer student who worked with us. We got some funding through the university, and she surveyed these women 5 years out from their delivery. And these women were an average age of 33. Of that group, 1 in 10 had had the fourth degree tear that goes right through the rectum. 90% had had third degree tear. So that involves some of the anal sphincter, but not all the way through. And we were looking at these women 5 years out with validated tools, looking at their pelvic floor distress inventory, the pelvic floor impact questionnaire, which determine the impact and severity of these symptoms. And we found that 7% of these women had weekly loss of formed stool, almost 20%, so 1 in 5 had weekly loss of loose stool, and almost 40% had inability to control flatus. So I also work collaboratively with Dr. Adrienne Wag, who's part of a international consortium on pelvic floor disorders. And it had been flagged in our Canadian Institute for Health Information data that our rates in Canada were quite high for these types of injuries. So back in 2004, the rates after forceps delivery were similar. We looked at nations, Austria, Sweden, Canada, Norway, because of similar healthcare situations and similar healthcare delivery models, similar socioeconomic demographic status. And in Norway, we were similar, but then Norway introduced an intervention in about 5 years ago. And then we've done follow-up surveys and shown that the rate in Norway decreased, but in Canada, our rate has actually increased, unfortunately. So, what happens is because these muscles are disrupted, patients don't have good control of their bowels and have significant health issues that lead them to seeking care. But the access to care is very inequitable. We can assess these injuries through ultrasound, and you can see on the left the normal sphincter and then the disrupted sphincter on the right. So I'm just going to briefly talk a little bit about muscles because these are a huge part of this issue. So as I mentioned, there's internal anal sphincter that provides most of the anal canal resting pressure to control stool. Sorry, I've lost my cursor here. And then there's also the puborectalis muscle that changes the anal continence mechanism. And this is hugely important for control of bowel. And then the other one is the external sphincter, which provides about a quarter of your resting anal pressure. So the big part of this is that physiotherapy helps manage these issues by working on the pelvic floor muscles. But because our teams were working independently, it became challenging to bring some of these pieces together. So we went with the initial data that we had from our pilot projects and surveys that we had done in 2010, we went to our health authority and our hospital group to look at ways that we could address the issue by creating a team for care. So we provided them with the data, had multiple meetings, and then were able to get some initial pilot funding to send a team to the United Kingdom where they have sort of the international model of care. And then we were able to set up a perineal clinic in 2011 to provide care for these patients. So then moving on from that, we started the perineal clinic, but obviously wanted to look somewhat at how our strategies had worked and also comparatively how we were doing compared to other centers. So we were supported by the Women's and Children's Health Research Institute and the Royal Alec Hospital Foundation. And we're able to look at a comparative study looking at the number of specialized perineal clinics globally, and then also look at our structure and uptake of the specialized perineal clinic at the Royal Alexandra Hospital in Edmonton, and look at whether we've had any impact on the care of these patients. So we did a review of literature, we had some qualitative interviews and also a quantitative component with chart reviews. So it's fascinating because despite where we are in 2023, the number of these clinics globally is actually quite low. The staff component varies significantly with its composition involving physicians, midwives, nurse practitioners, and physiotherapists. And then services provided, obviously dependent on staff and resources. Usually there's a standardized intake, and then they get an assessment and then have investigations based on the issue. But there are common themes that emerged that there is a significant impact of perineal trauma on women's biopsychosexual health. There is a lack of information for women on the exact nature of their injury and its consequences, need for education and training of healthcare providers on risk factors, and also a need for multidisciplinary clinics, and a need to gain greater awareness of clinics among the health providers and the frontline staff. So in terms of our situation, unfortunately, between our initial survey and our launch of our perineal clinic, there had not been significant change. Our rate of obstetrical anal sphincter injury was 6.6% in 2010 and 7% in 2016. However, we have had pretty good uptake of referral to the clinic, with about 2/3 being referred. We have then looked at barriers to access, and certainly access for people outside the urban center is significantly less. In terms of how our model functions, we actually do physio and nurse practitioner intake, and they do an initial education class and have one-on-one physio appointments, and then with other members of the team as indicated. Challenges have been failure to refer, lack of awareness of the issue amongst patients and providers, and again, this embarrassment and stigma around the condition. So the feeling from this initial study was that there was insufficient information provided to women on obstetrical anal sphincter injury and perineal trauma, including the short and long-term consequences and the existence of care to treat the sequelae. There was certainly a feeling from the qualitative interviews that specialized multidisciplinary clinics were needed, but certain such clinics can face multiple challenges that can be better understood and addressed through collaboration amongst healthcare care professionals and policymakers in the field. And there is still limited published data on these models of care. Another item that was identified as we were working through these.
Dr. Schultz, I'm sorry to interrupt you. This is Angela. Can you see me here?
Yeah.
I'm not sure how the thing works. Just if I can ask you to leave us with some concluding thoughts. We're just at time.
Oh yeah, for sure.
Oh, thanks so much.
So yeah, we did move on and then work with immigrant women and also looked at barriers to care. And this allowed us to partner with the Alberta Medical Association. And we were able to get a health advocacy grant to develop teaching modules for these patients in using partnerships with the multicultural health brokers. So I think, obviously I apologize for running over time here. So we're really fortunate in Edmonton to have some amazing partnerships locally. We have our Dale Shared Center for Solutions in Women Health and collaborations within the foundation and with Alberta Health Services. And we also have our Surgical Strategic Clinical Network. So I think my take-home messages are, it's really important to look at the patient population and the providers and the barriers to care, and then work with your partners, with your teams, providing evidence to then move forward with some of these smaller steps and models of care. Our next steps are going to be looking at our outcomes from our perineal clinic and our immigrant women's program and how they have impacted access and care for women. And I thank you for your time.
Thank you so much, Dr. Schultz, and I'll just thank you for really shining a spotlight on this issue that affects so many women, but I think many of us will agree it's just not talked about enough. So really, thank you so much for that. I also thank you for raising the priority of working with, you said patient partners and and women with lived and living experience as part of this policy-making journey. So I'll encourage everybody, please join me in thanking Dr. Schultz for that fantastic presentation. And I'll encourage you to add your questions, comments, reflections to the chat as I introduce our third and final speaker this afternoon, depending where you are. So please join me in welcoming Dr. Lorraine Lipscomb. Dr. Lipscomb is a senior scientist at Women's College Research Institute and a professor in the Department of Medicine, the director of the Novo Nordisk Network for Healthy Populations at the University of Toronto. And Dr. Lipscomb, we welcome you today to talk to us about addressing windows of opportunity to identify and prevent diabetes in women. Welcome.
Thank you very much for that lovely introduction. And it is my true honor to be here today to speak to you about some work that we have been doing around diabetes prevention in women. These are my disclosures. Before I begin, I would also like to acknowledge that I currently live and work in Toronto, which is covered by Treaty 13 and with the Mississaugas of the Credit. For thousands of years, Indigenous people did inhabit and care for this land and continue to do so today. And I am grateful to have the opportunity to work on this unceded land, and by doing so, give my respect to its first inhabitants. So these are the three objectives of my talk today. I'm going to just spend a little bit of time telling you about a particular unmet healthcare need that we sought to address for women with gestational diabetes. I'll describe our journey with the design and implementation of a novel diabetes prevention program for women and how we worked with the policymakers to help make that happen, and then finish off with discussing some of those strategies that we used and we're going to continue to use to partner with policymakers to make sure that we can translate evidence into action and respond to needs for women. I think there's something in the chat. Okay, so I'm going to continue. If anybody has a question, I guess we'll leave it till the end. Okay, sorry. Okay, so despite the fact that the prevalence of diabetes is actually greater in men than in women, diabetes actually does affect over 1 million Canadian women. And even though rates of diabetes have risen across all groups, work that we did several years ago now showed that young women under the age of 49 were the group that experienced the biggest increase in diabetes in Ontario. And the majority of diabetes cases are due to type 2 diabetes, which we know is at least partly modifiable and preventable through healthy diet and physical activity and weight control. And so this really underscored a need for me in my research to find opportunities to identify and reduce risk of type 2 diabetes in women, particularly young women. And what such opportunity is diagnosis of gestational diabetes, or GDM. As many of you know, this is a temporary condition of pregnancy that affects about 10% of pregnancies and about 21,000 Canadian women annually. We treat it during pregnancy to optimize fetal health. And although in majority of cases, the diabetes goes away after delivery, it is a marker of future type 2 diabetes in women. And indeed, evidence shows 7-fold higher risk of future type 2 diabetes if you've had GDM. And this risk rises early, with 20 to 50% being diagnosed in the first decade. So because this is a population that's actively engaged with the healthcare system, the pregnancy provides this stress test for them. This is an opportunity for us to intervene and help support women to help them prevent diabetes. However, the problem is that currently there's no formal diabetes follow-up after gestational diabetes, and the follow-up that is being offered is not effective. And so the way it works now is that women get active diabetes care during a pregnancy if they've had GDM, but once the baby is born, they're discharged back to their family doctor, and the family doctor is tasked with doing screening for diabetes postpartum and to offer diabetes prevention counseling. However, many women don't actually see their doctor during the postpartum period, and less than 50% even get tested for diabetes, and few are offered any sort of diabetes prevention counseling. We also know that family doctors may not have the capacity to be able to offer diabetes prevention support and may not have the training in how to do this effectively. And so this leaves women feeling abandoned. Studies have shown that they feel abandoned. They get mixed messages about whether diabetes is still an issue. Many of them don't really know what they're supposed to do about this information, that they're at higher diabetes risk. And we know this is a busy, demanding time for women where healthy behavior change is difficult due to the competing demands of motherhood. We also know that motherhood has a lot of gender-related roles associated with it that compete with self-care. So because of all of these issues, self-care comes last. And so we really needed to address this unmet need. This was a missed opportunity for diabetes prevention in a high-risk population of women. And so we sought to then try to figure out how can we address this unmet need. So first we needed to have a service and a program that women could access and stick with. We know that going to see their family doctor once to tell them that they needed to get more physically active and eat well has not been shown to be effective to help anyone make sustained behavioral changes, let alone this busy population of women. We also know that even if they were to go to group classes where they get some sort of education, that's also not been shown to be effective. And access is really not equitable across the healthcare system. Secondly, we needed to balance that with an effective program that has been shown to improve health behaviors and to prevent diabetes. And so we needed something that wasn't just a one-time visit, that actually offered evidence-based strategies to help women. And finally, because this is a problem that affects our population and is a healthcare problem, we felt that this type of service needed to be delivered in the healthcare system so that it was universally accessible and helped address this important this need. And so that started our journey to try and create such a program. And we called the program Avoiding Diabetes After Pregnancy Together with Moms, or ADAPT-M. And so we did, in the interest of time, I'm not going to tell you all of the steps we took to come to a proposal for a program. We did evidence reviews. We did a cohort study where we interviewed women. We surveyed women to understand barriers, facilitators' preferences. We did an environmental scan to understand what kind of programs are out there that we may borrow from. And this was the program we came up with. So we found evidence that the model of health coaching for at least 6 months has been shown to be effective in helping people make sustainable behavior changes. And so our program incorporated a health coach for a 6-month period, customized diet and physical activity education that's evidence-based, known to help prevent diabetes, behavior change techniques that are evidence-based, like goal setting, motivational interviewing, with regular follow-up offered virtually by the phone so that it was more accessible for women, more feasible, more flexible, and therefore would be associated with better access and retention. But then, then we wanted to try and test this program. So the first thing we wanted to do is, through our environmental scan, we found this cardiac rehab program at Women's College Hospital, and they actually offer 6 months of coaching for cardiac prevention. And so, just as a proof of concept, we enrolled a small number of women with funding from Lawson Foundation into this program, just to see whether this was something that was worth expanding upon. The concept of a 6-month health coaching program. Not only did we find high adherence and high satisfaction, but we actually showed significant improvements in fitness with this program. And so we were on to something. So the next step is we really needed to figure out, well, how do we spread and scale this program, adapt it for this new population of women who have gestational diabetes? Cardiac rehab wasn't the place for it. Family doctors are not equipped to provide 6-month programs of health coaching. And so we had to figure out, where could we go to deliver, to pitch this program and find resources to deliver it, and who are the right stakeholders to involve. And so we did look to where there might be capacity, and one place we thought would make the most sense was community-based diabetes education programs. They have certified diabetes educators there who are trained in helping support behavior change and diabetes education, but currently we're really focused on providing services for people with diabetes. There wasn't really anything there for diabetes prevention. Secondly, there were no programs that were 6-month in length and provided over the telephone. So this was going to be a bit of a pitch that we had to do to help to convince people that this is the kind of program that needs to be provided for this population, and that we're trying to convince people to add prevention in the portfolio for diabetes education programs. So we were actually lucky that the Ontario Ministry of Health just a few years earlier had launched their Ontario Diabetes Strategy. And we knew about this strategy, we looked at their goals, and we were able to align with those policy goals. You can see there were several goals of this strategy. One was around diabetes prevention. A second one was around clinical practice guidelines. It is in clinical practice guidelines to provide prevention services for women with GDM, coordination of diabetes services, and identifying gaps and implementing new initiatives. And so we were able to then, and furthermore, this pie chart shows you some of the new money that was put into the Ontario Diabetes Strategy for prevention initiatives and diabetes education programs. So knowing this strategy and finding a way to make a business case to align with these strategies, we were able to approach our local Toronto Central LHIN representative for diabetes services and convince them to provide support for us to at least pilot the program in Toronto Central LHIN diabetes education program. So that was our first step. And of course, with a view to providing evidence on feasibility, acceptability, and ultimately effectiveness. And so we were able to get, we created a broad stakeholder advisory board that had patients, providers, as well as our local policymakers from Ministry of Health and the Toronto Central LHIN to pilot this program with funding from Diabetes Canada. We were able to show high satisfaction, feasibility, and good retention for this population, 70%. We then went on to get CIHR funding to add more patients and roll it into an effectiveness trial. And we've just completed the trial. I don't have data yet, but one thing I can say is we have data to provide our policymakers about what is the actual resource implication of this program. It's 6 to 10 hours of a diabetes educator's time per patient. And so we can use that to try and do some cost analysis and add to, you know, what would be the trade-off between preventing diabetes cases and adding this 6 to 10 extra hours per patient. And even though we don't yet have evidence for diabetes prevention for these programs, while we were running our program, a number of other studies were published, and this is a meta-analysis of similar 6 or more month diabetes prevention programs focused on women with GDM offered within the first 3 years postpartum. And you can see when they combined the results, they were able to show a significant 43% reduction in type 2 diabetes incidence. And so this is the evidence that we really needed, in addition to the evidence we're collecting from our trial, to convince policymakers that you can actually prevent cases of diabetes with this kind of program and this early investment. There is a return on the investment. And so now our next step, we feel we have enough to move to implementation. No more trials, we need to be able to implement. But even implementation requires some research. And so we've just applied for a CIHR grant for an implementation strategy where we will actually expand our program beyond Toronto to 2 other Ontario jurisdictions. One of a couple of challenges have come up, though, over the years. As you all know, we now have a new government. The LHINs have dissolved and have moved to Ontario Health teams. We've had the teams have now shifted. Ontario Health has now shifted to more value-based care. There's no new funding for diabetes care. We need to reallocate resources. And of course, there was the COVID pandemic, which really made it hard for us to continue these conversations. So our strategy for this next phase has been to make sure that we present the evidence. Number two is we've partnered with York University that provides certification for health coaching for healthcare professionals. So we're providing that to diabetes education programs so that they can have certified health coaches that will be able to broaden the benefits of health coaching to other populations, that not just people at high risk of diabetes. We have local champions who have actually run the program or have benefited from it, and understand and align with what are the priorities now with the Ontario Health team that we could align with, this program could align with, and create a business case for that. This is the draft implementation plan from Ontario Health. I've put boxes around the three sort of priorities that we feel that we could justify our program aligns with. And this is our business case that we have provided to Ontario Health, and they've given us support now to pilot, to expand our program to 2 other jurisdictions. And you can see here, we've made the argument that our program will address the quintuple aim of healthcare improvement. And you can see the 5 aims here: equity and inclusion, population health, patient experience, care team well-being, and importantly, reducing costs. This government is very interested in value-based care and return on investment. And so we've made the case that by lowering the burden and cases of new diabetes, we're able to it will save the healthcare system about $4,000 per patient. Okay, and this, of course, we need to make sure that we have a broad leadership team that targets all stakeholders. And this is our schematic here, of course, including our policymakers there. This is a summary just of this part, and I wanted to leave maybe a few, 30 seconds to tell you about our network, because that's something that was of interest. But I've just summarized the points here, that we've shown you that there was a need for this type of program. We've shown you that we have evidence of feasibility and effectiveness and can be delivered in the healthcare system. The next step is to really translate the evidence into practice and create a business case for our policymakers. And I'd like to end off to say, although this is a step in the right direction, I'm really delighted that we could actually move upstream beyond the healthcare system and look at how can we work with policymakers to target the diabetes epidemic in the communities where we live and in the municipalities and living environments in which we live. And so the University of Toronto launched the Novo Nordisk Network for Healthy Populations last year, and I'm delighted to be the director. Our mission is to reduce inequities in risk and burden of diabetes and other chronic diseases through better care, lower risk factors, and healthier living environments. And we're working with local, regional, provincial, and national policymakers to help make this work. We're aligning with the WHO call to action to stem the diabetes epidemic, as well as the Mississauga Diabetes Strategy and the Government of Canada's new framework for diabetes in Canada. And I will end there thanking my great team of students, co-investigators, and my research team. And I will stop there. Thank you very much.
My goodness, thank you so much. That talk was absolutely brilliant. Please, everybody, join me in thanking Dr. Lipscomb today for that orientation to gestational diabetes and the power that intervening at that stage with that group of women can have towards larger diabetes prevention efforts. Absolutely fantastic, brilliant. Thank you so much. I am going to move us into the moderated discussion section, if that's okay with everybody. Is everyone still with me? Tamil, you've asked everyone to keep their cameras off, and then it makes it kind of weird because you don't know. Okay, some thumbs up. Folks are still with us. So what I'm going to do, we have a few questions from the chat in particular. And so I'm going to pose the first question actually to you, Dr. Norman, if that's okay. We have you've given us a lot to think about, but we have one kind of very practical question. So the commentator says, this is from Dr. Lori Brotto. She says, thank you for your wonderful talk. You mentioned that BC Women's Hospital was essential for forging the first links to government policymakers. So for those researchers who may not have these kinds of key links at hospitals, are there approaches that you might recommend?
Yes, absolutely. And there's so many pieces I'd be happy to elaborate on. If people are very welcome to ask questions in the chat or to write to me personally. I think this is a piece of a key strategy that one of my mentors, when I first was a clinician, frustrated with upstream difficulties where I could see there could be policy solutions potentially, and wanted to engage in research. I was fortunate to have the mentorship of Dr. Janusz Kazarowski, a phenomenal methodologist, and had a research director in our department at UBC at the time, and now has 2 different chairs in research at UD Montreal, and continues as one of Canada's leading primary healthcare researchers. And what he said to me was, you know, you're asking a question that has effects on lots of different populations. These are questions that are of interest to lots of health systems and services, and to healthcare professionals. Find those collaborators with whom you might already have been working or professionally knowing to some degree, and learn about their connections to those further up in the chain towards making decisions. And so each time you have some collaborator who trusts you and who can vouch for you, have them introduce you to the next person. And then when you meet that next person, find out who else would be engaged in the decision and is next up the chain, and have them introduce you. And so not just with, you know, being a physician working in BC Women's Hospital, asking my medical director if I could speak to the administration. These pieces, of course, worked my way up in the hospital, and eventually the hospital introducing me into government. But also when we went to look at connecting with the federal government and the different agencies, we looked to see who among our contacts in BC knew those within federal government that might be in portfolios of relevance. Also, our collaborating organizations. I had mentioned Action Canada for Sexual and Reproductive Health, but I failed to mention BC Women's Health Foundation, who is absolutely key in connecting with several of the federal departments that were able to, and willing and interested to listen to the case that we could bring, to bring our evidence to help assist them to achieve goals they had identified. So I think it is a broad question, Angela, and thank you for asking, Lori. It's really starting with what you've got and having that vision to see where you want to go, and working with the collaborations you have to be able to take the steps you need to get there. Is that helpful?
Well, I mean, I think it's it's achievable, and it's encouraging. That's how I heard your advice, is that it's encouraging and there's no magic bullet. Like it's understanding your ecosystem, understanding the stakeholders or players or contributors to that ecosystem, and their levers, right? We all have different levers. We're responsible for different accountability. So that really spoke to me. I think that's really practical advice.
There are 2 pieces also, if I can just elaborate a little on, that I've really been delighted out over this sort of decade of work. Now we've been passed to almost 24 different government divisions and departments for various pieces that the government might be interested in. And typically now the introduction isn't, here's Wendy Norman, you need to work with her. Now it's, we've been working with CART. They're a wonderful source of evidence to support government decisions. I'm introducing you to CART. And so my early career researchers and the others in our team now are as engaged. I was away for sabbatical for a year. My team took over and they did all of the government evidence work and advancing. So to be able to, much in the way that we were able to ensconce the sexual health survey as a government piece, being able to invest in your capacity building in your team, trust the researchers with you, take them to the meetings with government decision makers, and let them take over, let them move forward and advance their own careers.
Well, I think I'll just thank you for that call to action for all of the more senior researchers on this call around bringing along our trainees, our ECRs, and creating and opening up those opportunities, which is, I think, just such a fantastic call to action. Thank you, Dr. Norman. I'm going to pose a different kind of question to you, Dr. Schultz. You can let me know if you want to skip or pass. But something that struck me in all of your presentations was about resources, right? Like there's so much in the policymaking space that's about showing, return on investments or these cost savings. And I just wanted to ask you in your work, how that's played in, because you're at such a technical space within the healthcare system, right? You're in the surgery, space, and just wanted your reflections on how does that piece play in into the policymaking journey.
Yeah, that's a great question. Thank you. It's certainly a challenge when you're in that frontline health provision space, in addition to trying to do clinical research sort of simultaneously. You have these competing hats, obviously. So what I found really is you need to obviously include all your stakeholders, because it does in some instances become a bit of everyone's competing for that same pot of money, right? We're really fortunate in Alberta that we do have these strategic clinical networks, but one of the challenges I found in the women's healthcare space, which drives me a little crazy, is that we actually belong in different spaces. So one thing I'm super grateful for is the fact that our Women's Research Institute in Edmonton is women's and children's. But one of the challenges I've found, our strategic clinical network is maternal, newborn, child, youth. And my area, pelvic floor care, gynae cancers, endometriosis, fibroids, menopausal issues do not fit under maternal, newborn, child, youth, right? And we have challenges in other areas. Some of it you can fit under the surgery strategic clinical network, so you can collaborate with them and advocate at that level, because the strategic clinical networks are very closely tied to our government policy holders as well. So you need to be active and advocating in all these different spaces and sharing your findings and research so that there's awareness at multiple levels.
Thank you. That's such an insightful sort of just sharing your experience of kind of what it takes. And it actually leads me to a question that I was hoping to pose to you, Dr. Lipscomb, about expertise, like translating research evidence into policy change is an expertise. And sometimes as researchers, we either think we can do it all and go for it, or people expect us to do it all. So we sort of scramble to make it happen. And you did one of your slides, you showed, okay, you did your homework, the evidence review. What does the evidence tell us? You did your own research showing, the potential impact in your particular setting. And then you and I think a lot of researchers are familiar with those two steps. And then you had that first step, which is like, okay, wow. So can you just share with us, like, how do you think about the expertise and the resources that, you've kind of come to find as essential to taking that final step of the journey?
Well, I don't know. Thank you. That's a very important question. And thank you for asking it. And I don't know that I have the answers, and perhaps I'd be interested to hear if others have thoughts as well. But you're quite right that often researchers, academics, they have the evidence, they may have the passion, or even providers, like all of us are providers here. We understand what the needs are, but yes, you have to be able to communicate in an effective and compelling way in order to get the attention of the policymakers, particularly when it means that, there's going to be an investment, an ask for additional resources, and so, yes, I don't profess to, have like talent in that area. And so I guess I learned through, through mentorship from other people who've had experience. And I would invite anybody who's thinking to make that next step and try to make pitches to go to people who've done it successfully, like the people in this panel, to understand, don't just try to do it on your own, but figure out how best to do it. In our network, actually, if I could just tell you what our strategy has been, we actually have a person who is a science communication expert, and she is available to our researchers when they want to communicate with policymakers and knowledge users to try and translate their scientific idea and their scientific evidence into a relatable way and a compelling way. And so one example of how we made that happen was we had our first competition for people to apply for Catalyst grants to do projects for our network. And what we did is we then asked the finalists to come, and we invited policymakers and other knowledge users, patients, providers to a pitch event. And the finalists had to come and give a 4-minute pitch on their idea. And we had judges who were from Ontario Health, Public Health Ontario, the federal government, City of Mississauga, as well as providers and some research experts who judged them on their pitch. And anyway, but prior to them doing the pitch, we actually paired them up with our communications expert who helped them refine their pitch. So it is not an obvious step, right? There has to be some work. And I can tell you that the faculty members found this highly valuable to be able to learn how to pitch their idea in 4 minutes. And that's often all the time you get with a policymaker. You need to get to the point.
I mean, I think that's just such practical tip. We've tried to do the elevator pitch training in our own research team, and the people who are worst at it are PIs like myself. We are verbose and complicated in our language. And so I think that's just such a practical kind of challenge for all of us to get better at. Thank you. I'm going to ask one of our attendees, Julia, has asked, I think, what is a really interesting question, and I'd love to hear your reflections across the three of you in our final 3 minutes together, if that's okay. She's really kind of calling out, it seems like we've got to do a lot of this work of making sure that we make clear the cost savings, the healthcare benefits, et cetera. There's still going to be folks that are kind of outside, they're not quite on board yet. How do we get those folks on side? And she raises this suggestion of what role can values, value statements, make? And how can we kind of maybe even I don't mean this in a crude way, but leverage some of the values that institutions and policymakers are putting out there to bring these folks on side and promote, this movement from research into policy. I think this is a really thoughtful question. So I would love to give each of you 1 minute, 45 seconds. So Dr. Norman, can I start with you? Just your quick reflections.
Fabulous question. I think this has identified what I see as actually a key approach. The way myself and my members of my research team will talk about the aims and research that we are proposing to do will be directly related, and using the words of this published strategies for the knowledge user we're speaking to, whether that's a community-based organization or a government person. If we are talking to them, it's because they are supposed to do something with which we can assist. And so when we speak, we try to use their words, their phrases, their ways of framing their own goals. This is very similar to good advice for how to write a good grant. You look to see what the grant is offering to support and ensure that you are proposing research that meets those objectives. It's the same for talking with a policymaker. Find out what they need to achieve and demonstrate that you understand by using their own words and framing to talk about what you can bring to help them do that. Angela, I'm not sure if I've covered the question.
I think so. Well, I can see our two other panelists, Dr. Schultz, Dr. Lipscomb, really nodding enthusiastically. But Dr. Schultz, let me give you an opportunity to add any reflections you might have.
Yeah, I would echo what Dr. Norman said in terms of using their language to speak to them. I think the other thing that's important, I mean, it becomes a bit of a game, unfortunately, and it's really sad that advocating for women's healthcare has to be a game. But you have to, I think, look at what policymakers or government have identified as their priorities for their term, and then play within that environment, right? So even if it doesn't really fit the true niche or sort of cubby hole of what you are doing, you have to find a way to make it fit their cubby hole so that you are sort of supporting their vision and their mission with the work that you are doing.
Such pragmatic advice. So keep yourself in scope. Folks, I know we're at time, so if you do have to sign off, I'll just say thank you, but hopefully we can have 1 or 2 last minutes. Dr. Lipscomb, can you, I'll give you a chance to respond as well.
I'll be really quick because actually both Dr. Norman and Dr. Schultz echoed what I said, is you really want to align with what they want to do. You want to use their language. But another thing that really works is relatable stories, like being relatable. So actually, if you've got someone who's on the sideline, try to, like in my work, it's easy. Many people have had babies, and especially if they're women themselves, you can talk about, do you remember when you were postpartum? Or even a lot of the men policymakers have actually related to the stories that we tell, and the compelling sort of argument that these women need help during that period. They think about their own, partners and experiences they've seen in their families. And so making it relatable can help. Sometimes it's not always possible, but in my world, we were able to do that as well. And I found it worked.
Wow. I mean, 3 fantastic summaries and responses. So please join me in thanking our panelists today, and Tamil, over to you.
That I was simply going to thank our fabulous panelists, you, Angela, for your excellent moderation, and all of you for being here and engaging with us. We will be back in the same time and place on March 1st to talk about digital innovation for scale and scope. So stay tuned for that, and have a great rest of the day, everyone.